Welcome to the deep dive. Today, we are taking on a challenge that is, well, it's absolutely foundational to high-level clinical care. Forget the really rare diseases for just a moment. We are plunging into the management of non-malignant hematologic disorders.
Right.
These are the common, complex, and chronic conditions that affect millions of people. I mean, from global public health crises like iron deficiency all the way to the critical high-stakes management of something like a sickle cell crisis.
This is truly essential material.
Hmm.
When we exclude the malignancies, the sheer breadth of hematology we still have to master is it's enormous.
It really is.
We're discussing a complex system, involving red cells, white cells, platelets. All of them require really nuanced long-term nursing assessment and intervention. This material, distilled from the core medical surgical texts, isn't just about diagnosis, it's about mastering the care process.
That's why our mission today is so targeted. We are synthesizing a massive block of knowledge. Specifically, we're focusing on the clinical picture, the pathophysiology, assessment tools, and maybe most importantly,
The specific nursing interventions.
exactly, the nursing interventions for these non-malignant disorders. So if you are preparing for a meeting, a clinical rotation, or an exam, this is your deep dive, your streamlined guide to the absolute must-know insights.
To do that, we really need to be speaking the same language. Hematology is just full of critical calculations and terms.
Yeah.
So I think we should establish a common vocabulary first. Let's define the concepts that, truly structure the way we think about these disorders.
Okay, let's do it. Let's start with the red flags in the lab. Anemia, that's the big one. It's defined by a lower than normal hemoglobin concentration and a reduced number of circulating red blood cells, or RBCs.
Right. And reduced hemoglobin means reduced oxygen transport. It's always a sign of something else, never a disease unto itself.
Good point. And then we move to our immune defense, neutropenia.
A low neutrophil count. That's the most immediate warning sign for bacterial infection risk.
And closely related is lymphopenia, a lymphocyte count below 1,500 per cubic millimeter, which signals an increased risk for opportunistic infections.
And tying those white cells together is the calculation that determines that acute risk, the absolute neutrophil count, or ANC.
Right.
We calculate this based on the total WBC count and the percentage of segmented and banned neutrophils. And that number, the ANC, is the critical determinant of whether your patient needs protective isolation.
Now, when we talk about severe bone marrow failure, we use the term aplasia.
Which is the lack of cellular development. It's a scenario where the bone marrow, which is basically the factory, becomes severely hypoplastic or just empty, often replaced with fat.
That's a powerful visual factory floor that's completely shut down.
It is.
Okay, let's look at what happens when red cells break down too quickly, which is central to hemolytic anemias. When RBCs are destroyed, free hemoglobin gets released. And to clean that up, the liver produces haptoglobin.
Think of haptoglobin as a sort of tow truck service for damaged RBCs. If you have slow, steady damage, the tow trucks can handle it fine. But if you have massive destruction hemolysis, the body uses up all its tow trucks and the free hemoglobin just builds up.
So the key clinical insight is,
If haptoglobin levels drop, that's a massive clue that rapid destruction is occurring.
and the iron byproduct of that destruction is stored as hemosiderin. On the production side, we rely on the hormone produced by the kidneys in response to low oxygen, erythropoietin, EPO, which stimulates red blood cell production, or erythropoiesis.
And finally, the morphology. When we look at the RBCs under a microscope, we get immediate clues.
Okay.
Microcytosis means the RBCs are smaller than normal. Normocytic means they are normal size.
And the color.
Hyperchromia means they look pale because of low hemoglobin content. And normochromic means they have normal color. These characteristics are really the first step in differentiating the three major types of anemia.
Okay, we're armed with the language. Let's zoom in on anemia. As we established, it is the state of decreased oxygen-carrying capacity. But the real depth comes from understanding why the body is failing.
Absolutely. The classification system is built on three core pathophysiological mechanisms. Is the factory producing enough? Are the products durable enough? Or are the products just leaking out?
So that's hypoproliferative, hemolytic, and bleeding.
Exactly. Hashtag 1.1 anemia pathophysiology and classification.
So starting with hyperproliferative anemias, the factory failure, the bone marrow just isn't producing enough erythrocytes.
And the crucial diagnostic hallmark here is that the reticulocyte count, that measure of immature RBCs, is low, or it's inappropriately normal.
What does that mean, inappropriately normal?
Well, The body knows it needs more oxygen, so it should be pumping out more reticulocytes. If the count is just normal when the patient is anemic, that's a sign the bone marrow isn't responding like it should.
Got it. The factory isn't ramping up production.
Precisely. The causes are the things that hobble the factory. It could be physical damage from chemicals like benzene or certain medications. It could be lack of the signaling hormone, EPO, which we see most dramatically in chronic kidney disease.
Or the most common reason?
A lack of raw materials like iron, vitamin B12, or folic acid.
Okay. Next, the product destruction. Hemolytic anemias. RBCs are being destroyed prematurely. And this process, it releases hemoglobin, which converts to bilirubin, so the patient often presents with jaundice, right?
They do. And the body responds to this sudden tissue hypoxia by, pushing the panic button. It releases a massive surge of EPO. Therefore, the diagnostic fingerprint of hemolytic anemia is an increased reticulocyte count. The marrow is trying desperately to compensate for the rapid loss.
The causes can be internal defects like sickle cell disease or external insults like immune reactions or even the physical trauma from a mechanical heart valve shearing the cells as they pass by.
And the final, most deceptive mechanism, bleeding. Acute or chronic loss of cells from hemorrhage. And this is where the lab work can really fool you.
This is such a critical insight we need to synthesize. Right after acute blood loss, say from trauma or a massive GI bleed, the hemoglobin, hematocrit, and MCV can all look completely normal.
Yeah.
Because you've lost whole blood plasma and cells at the same rate.
Precisely. It's only hours later after fluid shifts that the HGB and HCT drop dramatically. And there's also a lag in the reticulocyte response.
So the marrow eventually starts pumping out new cells, resulting in an increased count.
But that initial deceptive normal reading is why your clinical assessment of volume status always supersedes the first lab draw in an acute hemorrhage.
Okay, now let's use the laboratory markers to classify these states. The source materials provide an amazing breakdown that allows you to walk through the diagnosis like a detective.
In hypoproliferative anemias, the reticulocytes are low. If it's iron deficiency, the cells are small, so low MCV or microcytic, and pale, which is hypochromic.
And the iron studies confirm this. Serum iron is low. But here's that insight we talked about. Total iron binding capacity, or TIBC, is high. Why is that high TIBC such a key finding?
Think of transferrin as the bus carrying iron around the body. TIBC is the measure of empty seats on that bus.
Okay.
So if you have no iron deficiency, the bus is driving around mostly empty. That means you have tons of unoccupied capacity, so a high TIBC. It's the body's way of saying, hey, I have plenty of space to carry the iron, I just don't have any iron.
That makes perfect sense. In contrast, megaloblastic anemias, B12 folate, show up with a high MCV. So they're macrocytic, but they still have low reticulocytes.
The factory is making these huge, useless cells because DNA synthesis is impaired.
Right.
Then you have anemia of inflammation, which is often normocytic. But here, the ferritin, the iron storage is high.
This is a classic lockup scenario.
It is. The iron is there. It's in the storage rooms, but the body locks it down as a defense mechanism against potential chronic infection or inflammation.
So iron supplementation is useless.
Completely useless because the body just won't release the stored iron.
And finally, the hemolytic anemias. The key triad is the increased reticulocyte count,
The marrow compensation.
elevated bilirubin,
The cell destruction byproduct.
and that critical drop in haptoglobin.
The exhausted tow truck service.
Okay, moving to symptoms. Tolerance to anemia is all about speed, isn't it? A young, healthy person can walk around perfectly fine with their hemoglobin gradually cut in half over 6 months.
Right. But a sudden 30% loss is catastrophic. It can cause circulatory collapse.
And we must never underestimate the impact of even mild anemia in older adults.
Oh, this is so important. Anemia prevalence is huge in the elderly population, about 17%. Even if the HGB is above 11, that reduced cardiac reserve significantly contributes to serious geriatric outcomes.
Like what?
Frailty, falls, decreased functional capacity, and cognitive decline. Their heart simply cannot compensate further when it's faced with an acute stressor. Hashtag tag 1.2. The nursing process for anemia, assessment to evaluation.
This brings us to the crucial application of the nursing process. Assessment has to be meticulous because anemia symptoms are so vague. I mean, fatigue, weakness, pallor.
They are. But the history holds surprising secrets. In iron deficiency, as the nurse, you have to ask about pica.
That's the bizarre craving for non-food items like ice, dirt, or starch.
Right. And also restless leg syndrome. These are unique clinical pearls that point specifically toward IDEA. Also critical is the full medication review flagging aspirin and NSAIDs for GI bleeding risk, or things like chloramphenicol that suppress the marrow.
The physical exam is equally revealing. We look for pallor, of course, but also specific signs like angular cheilitis, those mouth corner fissures, or brittle ridged nails.
And the tongue is a massive diagnostic clue. It's smooth and red in IDA, but it's sore and beefy red in megaloblastic, the B12 and folate anemias.
Okay, so the systemic review focuses on the two systems that get hit the hardest.
Cardiac.
Tachycardia, palpitations, eventual signs of heart failure like edema or hepatosplenomegaly, GI glossitis, melena, or occult blood.
But the neurologic assessment is the separator. This is key. If you see peripheral numbness, paresthesias, that's the tingling or pins and needles ataxia, which is difficulty with gait, loss of position or vibration sense, confusion, or delirium.
You're staring directly at vitamin B12 deficiency.
Yes. Not folate or iron deficiency,
Oh, yeah.
only B12.
Based on this, the nursing diagnoses are pretty clear. Fatigue, impaired nutritional status, activity intolerance. And our collaborative goals are preventing the big problems. Heart failure, paresthesias, confusion, and falls.
The interventions start with managing fatigue, which is often the patient's #1 complaint. It's the primary barrier to their quality of life. The nurse's priority is assisting the patient to prioritize activities, find that necessary rest activity balance, and start a graduated exercise program to prevent the cycle of deconditioning.
Regarding nutrition, education is essential. We have to promote a well-balanced diet, but also caution the patient against excessive self-supplementation, especially for those who are getting long-term transfusions and are actively trying to fight iron overload with chelation therapy. Giving them extra iron would be, well, highly detrimental.
Absolutely. And managing activity intolerance often means rapid intervention in acute cases, transfusions or IV fluids to replace volume. Supplemental oxygen might be required, but it always means meticulously monitoring vital signs and pulse oximetry, particularly when the patient moves, to ensure perfusion is maintained.
Finally, adherence to therapy. The nurse needs to prepare the patient for the side effects of oral iron, the cramping, the nausea, the constipation.
Yeah, that's a big one.
And teach them strategies, like gradually increasing the dose to improve tolerance and compliance over the necessary 6 to 12-month course.
The evaluation checks for concrete outcomes. Is the patient reporting less fatigue by pacing their activities? Are they adhering to their supplements? Are they maintaining a safe activity level with stable vitals? And crucially, are they neurologically stable, oriented, and safe?
Okay, time to dissect the major factory failures, starting with iron deficiency anemia, the most prevalent anemia worldwide. Hashtag 2.1 iron deficiency anemia.
IDA. IDA occurs when iron intake is insufficient for hemoglobin synthesis, or more often in the developed world, when there is chronic occult blood loss.
And we have to remember that HGB levels don't drop until the body's iron stores, the ferritin, are completely exhausted.
That's right. The etiology dictates the search. For men and postmenopausal women, the assumption must always be GI bleeding until you prove otherwise.
And for premenopausal women,
It's typically heavy menses or pregnancy. And of course, chronic NSAID or aspirin use and alcohol intake are always major risk factors for chronic loss.
we covered the specific physical manifestations: smooth red tongue, pica, brittle nails. The diagnosis relies on those three key lab findings: low ferritin, which is the first to drop, low serum iron, and that counterintuitive elevated TIBC.
And the resulting anemia is microcytic as it progresses.
Management is focused on oral iron, which sounds simple, but compliance is notoriously difficult. Ferrous sulfate is the standard.
And this is where nursing education is absolutely paramount. To maximize absorption, the patient must take oral iron on an empty stomach.
So 1 to 2 hours away from meals.
Exactly. And ideally with vitamin C, like a glass of orange juice.
But the compliance killer is the GI distress. Iron is highly irritating. If the patient experiences crippling constipation, cramping, and nausea, they will often quit within a week.
They will. So the nurse needs to counsel on gradual dose increases and managing constipation with fiber and stool softeners. And if they have to take it with food to reduce nausea, they must understand that absorption drops by 40%.
Which significantly extends the required 6 to 12-month replenishment period.
Right. And the practical pointers: warn them about dark or black stools so they don't panic. And if they're using liquid preparations, use a straw to prevent tooth staining. The education has to stress the need to continue therapy long after symptoms resolve to fully stock those depleted ferritin stores.
And if oral therapy fails, we move to parenteral iron. Thankfully, newer low molecular weight formulations like iron sucrose have dramatically reduced the anaphylaxis risk associated with the older types.
They have. Yet, even with the newer iron, close monitoring for hypersensitivity is still required. Often these formulations are used for patients who need significant amounts of iron quickly or who have chronic conditions like hemodialysis where oral absorption is just insufficient. The nurse must be vigilant during the infusion. Tag 2.2. Other hypoproliferative anemias.
Now for the rest of the factory failures.
Anemias in renal disease are a function of EPO failure. The severity increases dramatically when the glomerular filtration rate, or GFR, drops below 30.
And reduced EPO means reduced production.
Which leads to low cognition, reduced libido, and increased strain on the heart. It's often complicated if the patient also has diabetes.
Then there's the deceptive anemia of inflammation, or AOCD.
Associated with chronic illnesses, cancer, or aging, this is usually a mild normocytic anemia. The factory is fine and the iron stores are present high ferritin, but the body's inflammatory response locks the iron away from the erythroid cells.
The key insight again, don't give iron.
Exactly. Treatment must target the underlying inflammation or chronic disorder. Supplementation will not help, and it might even be harmful.
Now, the most dramatic failure is aplastic anemia. This is rare, but it's a life-threatening bone marrow failure resulting in pancytopenia.
A total shutdown of RBC, WBC, and platelet production.
And it's an immune-mediated catastrophe where T cells attack the hematopoietic stem cells.
It is, and it leads to insidious symptoms. Severe fatigue and pallor from the anemia, unrelenting infection risk from the neutropenia, and bleeding or purpura from the thrombocytopenia. Retinal hemorrhages are often noted.
The dilemma in management really centers on age, doesn't it?
It does. If the patient is under 60 and otherwise healthy, a curative hematopoietic stem cell transplant, or HSCT, is the priority. For older or less fit patients, we turn to powerful immunosuppressive therapy like antithymocyte globulin, ATG, and cyclosporine to stop the T-cell attack.
So nursing care here is defined by high risk, infection, and bleeding vigilance. The medications are potent.
Extremely. We monitor for ATG side effects like fever, serum sickness, and anaphylaxis, and for long-term cyclosporine complications like renal dysfunction, hypertension, and tremors. And patient education is vital. Abrupt cessation of these immunosuppressives is extremely dangerous.
Finally, let's revisit the megaloblastic anemias B12 and folic acid deficiencies, where DNA synthesis failure leads to large, useless cells, high MCV, macrocytic.
Folic acid deficiency is fast. The stores deplete within months due to inadequate diet, alcohol abuse, or pregnancy. Treatment is simple: diet and a daily 1 milligram supplement.
But vitamin B12 deficiency is slow. It can take years to develop, usually due to malabsorption, which is common in older adults or after GI surgery. Pernicious anemia is the specific subtype due to a lack of intrinsic factor, or IF.
And we must reinforce that critical distinction. Both cause anemia symptoms and a smooth red tongue, but the presence of neurologic symptoms
Paresthesias, gait disturbance, confusion, loss of position sense
is the unique hallmark of B12 deficiency. Folate deficiency does not damage the nerves.
So treatment for B12 deficiency, especially pernicious anemia, means lifelong replacement, often via monthly IM injections.
That's right. The nurse's role is critical in conducting detailed neurologic assessments and prioritizing patient safety against falls due to impaired coordination. We have to stress that adherence is lifelong, and neurologic recovery may be incomplete if the neuropathy is severe before treatment begins.
We're transitioning now to the destruction disorders characterized by rapid RBC turnover and high reticulocyte counts. And the most impactful and devastating example is Sickle Cell Disease, SCD. Hashtag 3.1, Sickle Cell Disease, SCD.
SCD is an inherited autosomal recessive disorder where defective hemoglobin, HbS, causes the RBCs to become rigid, sickle shapes, when they're exposed to low oxygen tension.
The core pathophysiology is this cascade of damage. These rigid sickled cells get trapped in the microcirculation, causing decreased blood flow, ischemia, and infarction.
And the result is the hallmark symptom: the excruciating vaso-occlusive crisis, or VOE. It's characterized by severe pain, swelling, and fever.
The environmental trigger is so crucial for patient education. The sickling is initially reversible, but triggers like cold can cause vasoconstriction, slowing blood flow and precipitating a painful crisis.
This is a critical point we will come back to in pain management.
This disease primarily affects people of African descent with high prevalence rates. Genetic counseling is vital for carriers, as 2 carriers have a 25% chance of having a child with the most severe form, sickle cell anemia.
The clinical manifestations are split between chronic hemolysis, which leads to chronic anemia, with a HGB of 5 to 11, jaundice, and cardiac strain, and the relentless organ damage from thrombosis and infarction in the lungs, spleen, CNS, and kidneys.
Okay, let's detail the crises. The acute VOE is the severe pain episode we just mentioned. Then there's the aplastic crisis.
This is a sudden, rapid drop in HGB, often triggered by human parvovirus. It leads to bone marrow failure and zero reticulocytes.
Then there is the pooling, or sequestration crisis, where cells pool in organs like the spleen in children or the liver and lungs in adults. That leads to severe volume shifts and potential shock.
Right.
The complications demand immediate attention. Acute chest syndrome, ACS, is the leading cause of death in young adults with SCD. It presents as fever, respiratory distress, and new chest infiltrates.
The management for ACS has to be aggressive and immediate. Antibiotics, transfusions, bronchodilators, and religious use of incentive spirometry to prevent atelectasis. Failure to recognize or aggressively treat ACS can lead rapidly to respiratory failure.
Pulmonary hypertension, PH, is another stealth killer. It's often diagnosed late when it's already advanced. Symptoms are vague fatigue and dyspnea on exertion.
Screening with Doppler echocardiography and monitoring high brain natriuretic peptide levels are essential to predict mortality risk.
And the risk of stroke is profound, especially in children, with ischemic stroke being the most common. Transfusion therapy is non-negotiable here.
The goal is keeping the defective HBS concentration below 30%. We also have to recognize the high prevalence of silent cerebral infarction, which causes neurocognitive decline without overt symptoms.
We should also touch on the major impact on reproduction. Men often face hypogonadism, low libido, and impotence, and the medical emergency of priapism.
A prolonged, painful erection. It requires immediate medical attention to prevent permanent damage.
For women, delayed menarche and increased obstetrical risk are common. Hashtag 3.2 medical and nursing management of SCD.
Management focuses on improving quality of life, preventing crises, and treating acute events, knowing that average life expectancy is, unfortunately, reduced.
HSCT offers a potential cure, but is limited by the availability of donors and the patient's health status. The vast majority of patients rely on pharmacologic and supportive therapies.
Hydroxyurea is the cornerstone drug. It works by increasing fetal hemoglobin, HGBF, which resists sickling. Studies show a 40% reduction in mortality.
But the nurse must counsel patients on the side effects: chronic leukopenia and, critically, teratogenesis.
Yes, contraception is absolutely mandatory for women of childbearing potential.
Transfusion therapy is life-saving for acute exacerbations, but it introduces serious long-term risks specific to this population.
It does. First, iron overload from chronic transfusions mandates the use of iron chelation therapy. Second, the risk of alloimmunization is extremely high. Developing antibodies to many different blood antigens makes future cross-matching a nightmare and contributes to organ damage.
We need to acknowledge the unique danger of the hemolytic transfusion reaction in SCD. It mimics a crisis, but leads to a worse anemia post-transfusion.
Right. Vigilance is necessary, and it often requires corticosteroids.
Let's focus on pain management, which is so central to care and often the most contentious point. Acute VOE pain is unpredictable and severe, requiring aggressive analgesia parenteral opioids, often via PCA.
And here is where the discussion on trust in patient care must be prioritized. Research has shown that reducing the time it takes to administer analgesics from, say, 92 minutes down to 62 minutes significantly increased patient satisfaction and decreased treatment time.
Why is this so critical?
Because this patient population is often stigmatized and perceived as drug-seeking, which leads to delays and an erosion of trust.
So the nurse must actively work to bridge that gap.
Yes, by providing prompt pain relief based on the patient's assessment of their own pain without judgment. For chronic pain, the goal shifts from elimination to maximizing functioning using non-pharmacologic strategies like heat, massage, and cognitive therapies.
Here's a critical intervention alert. When treating joint pain during a crisis, use heat packs. The source is very clear. Avoid cold packs or ice, as cold may precipitate sickling by causing local vasoconstriction and slowing blood flow.
So important. In the nursing process for sickle cell crisis, assessment must be exhaustive. Detailed pain history, hydration status, cardiopulmonary assessment for ACS signs, and a meticulous neurologic exam. We also have to inspect the skin for those chronic, slow-healing leg ulcers common in 75% of adults, which require dedicated aseptic wound care.
Interventions focus on prompt analgesia, fostering coping skills to reduce feelings of powerlessness, and aggressive patient education on crisis prevention hydration, avoiding cold, and infection risk reduction.
And home care demands that the patient takes lifelong responsibility. They must understand the risk of hydroxyurea and the necessity of contraception. Given the unpredictable nature of the disease, coordinated multidisciplinary care, perhaps through a patient-centered medical home, is essential for stability.
We need to move quickly through the remaining red cell disorders that cause structure or enzyme problems before we tackle the white cells. Hashtag 4.1. Other hemolytic anemias and iron overload.
Thalassemias are hereditary hemolytic anemias caused by impaired hemoglobin synthesis. This leads to cells that are extremely microcytic and hypochromic. The excess, misfolded globin chains precipitate, making the cells rigid and easily destroyed.
In the severe form, thalassemia major requires regular PRBC transfusions to maintain life, which, like SCD, mandates concurrent iron chelation therapy to prevent organ damage from iron overload.
Next is the enzymatic defect. Glucose 6-phosphate dehydrogenase deficiency, or G6PD.
This is an X-linked disorder resulting in a defective enzyme that destabilizes the RBC membrane, so patients are fine until they encounter a trigger.
Exactly. The nurse's role here is pure education. Hemolysis results when the patient is exposed to oxidant drugs like sulfadiazine or dapsone, or surprising dietary items like fava beans, menthol, tonic water, and certain Chinese herbs.
And treatment is just discontinuing the offending agent.
That's it. Patients have to avoid these substances for life and wear a medic alert bracelet.
Immune hemolytic anemias involve antibodies attacking the RBCs. The warm body type, which reacts at 37 degrees Celsius, is most common and treated aggressively with high-dose corticosteroids. Splenectomy is second line.
And there's a crucial safety alert here. When autoantibodies are present, cross-matching blood is extremely difficult.
So if an imperfectly matched unit is necessary,
the nurse must infuse it very, very slowly, 10 to 15 milliliters over the first 20 to 30 minutes, with meticulous monitoring for a reaction. And patients with cold antibody types should be counseled to avoid cold temperatures entirely.
Now let's look at primary iron overload, hereditary hemochromatosis. This genetic disorder causes excessive iron absorption, depositing iron into organs like the liver, heart, and pancreas.
The damage is gradual but devastating. Weakness, joint pain, bronze or hyperpigmented skin, heart arrhythmias, and ultimately liver cirrhosis with a high risk for hepatocellular carcinoma.
The management is elegantly simple, though. Therapeutic phlebotomy.
The removal of whole blood, typically weekly until ferritin levels drop below 100. Aggressive blood removal is the only way to prevent end organ dysfunction.
So nursing education here involves advising patients against iron or vitamin C supplements,
because vitamin C enhances iron absorption.
Avoiding excessive alcohol and ensuring family members, siblings, and children are screened. Hashtag 4.2 white blood cell disorders.
Shifting to the immune defense system, we focus on neutropenia, defined as a neutrophil count less than 2,000. The risk of infection, often from the patient's own endogenous flora, like from the GI tract or skin, just skyrockets.
The danger is quantified by the ANC. The risk becomes serious below 1,000, and the patient is considered at high risk for overwhelming infection when the ANC drops below 500.
And here is the critical quality and safety alert. Fever is the most common sign of infection, but it can be absent if the patient is elderly or taking corticosteroids.
So fever in a neutropenic patient is always
an assumed infection until proven otherwise.
Management is immediate. If a fever occurs, cultures, blood, urine, etc. must be drawn immediately, and broad-spectrum antibiotics started immediately afterward without waiting for culture results.
Right, and growth factors like GCSF or GM-CSF can be used to stimulate marrow production when the cause is failure to produce.
The nurse's role in prevention is extensive. Education, and we often use a specific checklist for this, includes meticulous hand and oral hygiene, avoiding crowds, people with infections, and cautioning against environmental risks like gardening, so soil exposure, bird cages, and litter boxes.
And we should also address the less common lymphopenia, a low lymphocyte count. This increases the risk for opportunistic infections if T cells are low, or bacterial infections if B cells are low, often caused by radiation, corticosteroids, or certain viral infections like HIV.
We now enter the complex realm of hemostasis, where the slightest imbalance can lead to disaster. Hashtag 5.1 platelet and coagulation defects.
When a patient is bleeding, the first step is classifying the defect. Platelet defects, either a low count or poor function, cause superficial bleeding.
So petechiae, those tiny capillary hemorrhages, easy bruising, mucosal bleeding like nosebleeds or heavy menses.
Exactly, and this bleeding is often controllable with pressure.
In sharp contrast, coagulation factor defects cause deep bleeding, hematomas in muscle, or painful hemorrhage into joint spaces, which is hemarthrosis.
And this deep bleeding often continues slowly, recurring hours after pressure is removed.
This guides the home care education checklist. Patients at risk for bleeding have to avoid trauma, use electric razors and soft toothbrushes, and avoid any rectal instrumentation suppositories, enemas, temps, or IM injections if their counts are low.
And they must also avoid aspirin, NSAIDs, and alcohol.
Thrombocytopenia is a platelet count below 150,000. Bleeding risk rarely becomes serious until the count is below 50,000.
But the risk of spontaneous fatal CNS or GI hemorrhage rises dramatically when the count falls below 5,000.
The causes are the familiar mix: decreased production from chemo or alcohol, or increased destruction from sepsis or DIC. Management targets the underlying cause.
And the most common acquired immune condition is Immune Thrombocytopenic Purpura, or ITP. It's often seen in young women. Antibodies destroy platelets even as the marrow tries to compensate.
Manifestations include easy bruising and heavy menses. And wet purpura mucosal bleeding in the GI or respiratory tracts is a red flag for life-threatening hemorrhage.
The goal is simply to maintain a count high enough for hemostasis, so above 30 to 50,000. High-dose corticosteroids are the primary treatment. Splenectomy is a second-line option for a sustained increase, but it requires lifelong vigilance for infection.
Now here is a critical nursing insight for ITP.
Yes.
Platelet transfusions are often ineffective and potentially dangerous. Because the patient's own antibodies are actively destroying platelets, transfused platelets are immediately coated with antibodies and destroyed, consuming factors and potentially worsening the bleeding state.
Right. We also deal with qualitative platelet defects, a normal count, but abnormal function. Aspirin is the classic example, impairing function for several days. Management is stopping the offending agent, and the list of medications that impair function is long and includes many common supplements. Desmopressin might be used before necessary procedures. Hashtag 5.2 inherited coagulation disorders.
The inherited factor deficiencies are hemophilia and von Willebrand disease, VWD.
Hemophilia A, which is Factor VIII deficiency, and Hemophilia B, Factor IX deficiency, are X-linked and thus far more common in males. Classification is based on the small percentage of factor activity that's remaining.
And the clinical picture is defined by deep bleeding, especially into the joint's hemarthrosis, which causes pain, swelling, and eventual severe joint arthropathy and disability.
Intracranial or extracranial hemorrhage demands immediate factor replacement.
Management is immediate replacement of the deficient factor, using recombinant factor 8 or 9 concentrate upon bleeding onset or prophylactically. The most serious complication is the development of inhibitors.
Neutralizing antibodies, which make replacement therapy useless.
Newer therapies, like the monoclonal antibody emicizumab for hemophilia A, are emerging to address that inhibitor problem.
And geriatric care for hemophilia is complex. Older patients often carry liver disease risks from receiving factor concentrates before 1985. And managing common cardiovascular diseases, which may require antiplatelet therapy, becomes extremely high risk, requiring intensive factor replacement.
Now, von Willebrand disease, VWD, is the most common inherited bleeding disorder affecting 1% of the population. It's an autosomal dominant deficiency of VWF, which is needed for both platelet adhesion and factor VIII activation.
And since VWD affects platelets, the bleeding is primarily mucosal: nosebleeds, easy bruising, and very heavy menses. Joint bleeding is rare, except in the most severe type.
Treatment involves replacing VWF and factor VIII. Desmopressin can be used for mild VWD, as it transiently increases factor VIII. But nurses must monitor closely for the risk of hyponatremia with repeat doses. Hashtag 5.3 acquired coagulation disorders.
Several acquired conditions can derail the clotting cascade.
Liver disease is a major offender, as the liver synthesizes almost all clotting factors. Dysfunction leads to reduced factors, a prolonged PT, and high risk of life-threatening hemorrhage, requiring fresh frozen plasma, or FFP.
Vitamin K deficiency, often caused by malnutrition or long-term antibiotics wiping out gut flora, is easily corrected with oral or subcutaneous vitamin K, which is phytonadione.
Okay, now for the true paradox and high-stakes acquired condition, heparin-induced thrombocytopenia, or HIT. This affects up to 5% of patients exposed to heparin.
And this is a devastating mix of too much bleeding and too much clotting. Antibodies form against the heparin platelet complex, causing the platelet count to drop severely, usually 50% or more, about 5 to 10 days after starting heparin.
But here is the paradox. This is a prothrombotic state.
It is. The activated platelets cause massive thrombosis VTE, stroke, acute coronary syndrome, and limb loss.
The nursing intervention is urgent and decisive. Immediate cessation of all heparin. That includes flushes, heparin-coated catheters, and IV solutions. The patient must immediately be started on alternative anticoagulation, such as argatrobin.
And here is the major safety warning. Warfarin is contraindicated initially.
Why is that?
If you start warfarin too soon, it causes an acute drop in protein C, which is a natural anticoagulant. This dramatically promotes thrombosis, potentially leading to devastating skin necrosis or gangrene. This condition requires extreme vigilance and knowledge of the mechanism.
We end with the ultimate clinical crisis. Disseminated Intravascular Coagulation, or DIC. Hashtag 6.1. Disseminated Intravascular Coagulation, DIC.
DIC is a systemic syndrome triggered by a massive underlying event sepsis, severe trauma, cancer, or an obstetrical emergency. It creates a state where the patient is simultaneously clotting uncontrollably and bleeding uncontrollably.
It's the ultimate metabolic contradiction. If we use a visceral analogy, it's like the patient is fighting a fire that is both burning and drowning them simultaneously.
That's a good way to put it. Inflammation triggers massive systemic coagulation, which consumes all the body's platelets and clotting factors.
So the initial uncontrolled clotting leads to microclots in every organ, causing ischemia and failure.
But because all the factors are used up in this initial clotting frenzy, the coagulation system fails, leading to life-threatening hemorrhage. And to make matters worse, the massive clotting triggers fibrinolysis, which releases anticoagulant products like D-dimer and FDPs that further worsen the bleeding.
The clinical manifestations reflect this terrifying duality. The first sign might just be a progressive drop in platelets. But as it progresses, we see signs of thrombosis, hypoxia, decreased pulses or sensation, kidney injury, and bleeding.
Petechia, oozing from multiple sites, hematemesis.
Diagnosis relies on lab findings that confirm consumption and breakdown. Low platelets, low fibrinogen, prolonged PT and a PTT, and highly elevated D-dimer and FDPs.
And the International Society of Thrombosis and Hemostasis uses a clinical scoring system based on these labs. A score of 5 or more indicates overt DIC.
The single most critical management principle is, you must treat the underlying cause.
Absolutely. If the patient has sepsis, the sepsis must be controlled. If the patient has trauma, the source of tissue injury must be addressed.
Supportive care involves replacing depleted factors, like cryoprecipitate for fibrinogen and factors 5 and 8 for serious hemorrhage. The use of heparin is highly controversial and requires individualized assessment.
Right. It might be used for predominantly thrombotic DIC to interrupt the microclotting, but it must be monitored closely via fibrinogen levels.
So the nursing care plan for DIC is defined by vigilance and protection. We have to identify at-risk patients and frequently assess for subtle signs of both clotting and bleeding. Monitor LOC, vital signs, and organ perfusion like urine output and O2 saturation.
And we must meticulously protect the patient from trauma. This means avoiding activities that increase intracranial pressure, like coughing or straining, avoiding all rectal and IM injections, using gentle oral care, and applying prolonged pressure at least 5 minutes after any necessary procedure. Meticulous hourly skincare and repositioning are mandatory to prevent breakdown. Hashtag 6.2 thrombotic disorders.
Finally, we examine the conditions of primary hypercoagulability.
Secondary thrombocytosis is an increased platelet count, usually reactive to inflammation, infection, or splenectomy. The function is normal, so thrombosis is rare, and treatment targets the underlying disorder.
Hypercoagulable states, or thrombophilia, are conditions causing excessive thrombosis, either inherited or acquired. Risk factors include contraceptives, obesity, immobility.
Inherited examples include the Factor V Leiden mutation, which is the most common inherited cause in Caucasians. It causes resistance to natural anticoagulation. Homozygous patients are at extreme risk and require lifelong anticoagulation.
We must also reiterate the serious acquired condition linked to factor deficiencies, protein CS deficiency.
When warfarin is initiated in these patients, it can cause severe thrombosis and warfarin-induced skin necrosis, necessitating immediate cessation of warfarin, vitamin K, and alternative anticoagulation.
Another acquired cause is antiphospholipid antibody syndrome, associated with stroke and miscarriages. And malignancy, especially pancreatic or lung cancer, also dramatically increases VTE risk, often requiring LMWH instead of warfarin for treatment.
The management of all these thrombotic disorders centers on anticoagulation. The nursing role is critical in counseling patients to avoid circulatory stasis immobility, crossed legs, and encouraging frequent ambulation and exercise.
We must stress avoidance of concurrent risk factors like tobacco and uncontrolled hypertension. And for patients with hereditary disorders, encouraging siblings and children to undergo testing is a necessary step for lifelong prevention. Hashtag outro.
We've completed a comprehensive, deep exploration of this critical chapter, navigating the spectrum from simple nutritional deficiencies all the way to the catastrophic complexities of DIC and HIT. We specifically synthesized the high-impact clinical pearls: the diagnostic triad of hemolysis, the unique neurologic fingerprint of B12 deficiency, the critical role of hydroxyurea in SCD, and the immediate life-saving protocols required for neutropenic fever and DIC.
The consistent takeaway is the immense responsibility of the nurse across all these conditions, providing meticulous, non-judgmental pain assessment, ensuring patient safety against bleeding and infection, and delivering specialized education on adherence and complication avoidance.
So here is our final provocative thought for you, the learner. In hematology, every single intervention carries a necessary risk. You are constantly balancing the essential, like administering a life-saving transfusion against the life-threatening complications of iron overload or alloimmunization, or balancing immediate pain relief against the long-term risk of stigma and dependence. Mastering this field means truly mastering that high-stakes, individualized balance of care for every single patient.